Now, infection of the endocardium is infective endocarditis. Okay. Infection of the arterial wall is infective arteritis. Now, what is the cause of the infection in the endocardium? This is important. Every time we do something, suppose there is some minor trauma in the skin, just minor trauma. There is bacteremia, means bacteria present in the blood. Dental brushing, or some dental procedures. In those cases, there is presence of bacteria in the blood. There is bacteremia. But that bacteria can be cleaned by the body's defense system. Normally, the endothelium, that is inner lining of the artery, or endocardium, that is inner lining of the heart, they are not sticky. That is, they have defense against the bacteria. So, bacteremia, when the blood is present in the blood, it may be present every time when we do some procedure, that is dental, say tooth brushing, or some tooth operation, dental things, or say some skin piercing, during taking some injection, during some trauma. In all the time, there is some chances of bacteremia there. So, that bacteremia does not cause the infection of the endocardium or endothelium. The reason is that the body is capable enough for destroying that bacteria. But if there is any damage of the inner lining of the artery, or if there is any damage in the endocardium, then there are chances of the bacteria to get lost in that particular area. So, what is the difference between septicemia and bacteremia? Bacteria means bacteria is moving in the blood, but there is no multiplication of the bacteria. Septicemia means bacteria present in the blood with multiplication. Multiplication. There is a large number of bacteria forming from single. So, when there are multiplication, the chances of formation of septic emboli, that can give rise to different diseases. So, in normal subject, the bacteria are present always, and as per the incidence, not from our, but from other countries, they say the incidence of bacteremia may be from 10 to 80% during some procedures. But those bacteria are killed or removed by the body's defense system. Body's defense system fails to remove the bacteremia when there is. So, you must know the difference between bacteremia and septicemia. So, infective endocarditis, where there is infection of the endocardium. There may be other terms like non-infective endocarditis. We are not dealing with that portion. It may occur in SLE, Liebman sac endocarditis, or it may occur in some cancer, carcinoid syndrome. Cancer. There may be non-infectious endocarditis. But we are dealing with infective endocarditis. So, a normal endocardium is not infected, except some few conditions. But what are the abnormalities which can give rise to infective endocarditis, infection of the endocardium? Let us consider there is some damage of the endocardium. There is some damage of the endocardium, and if there is any damage due to rapid flow or jet flow of the blood, due to some, say, heart disease, there may be damage of the endocardium. Now, any of you, say last bench, second from the right. You stand up. Tell me one condition where the endocardium may be damaged due to flow of the blood. Huh? can be damaged. ব্যাগটা নিয়ে এসো, ব্যাগটা নিয়ে এদিকে এসো। এত গল্প করবো, বাইরে যেয়ে গল্প করতে পারো। হ্যাঁ, পড়াশোনার একবার নাম নেই, শুধু শুধু ক্লাসে এসে বসে থাকে। So when there is a damage may occur due to flow of the blood giving rise to endocardial damage. Suppose there is ventricular septal defect where the left-sided blood with more force is going to the right side. There may be damage of the endocardium. Or suppose there is aortic regurgitation or aortic stenosis. The forces of the blood can damage the endocardium. That can give rise to damage of the endocardium. Or suppose the valve, there is regurgitation of the mitral regurgitation due to rheumatic heart disease. That can give rise to damage of the endocardium because the force of blood is giving thrust to the endocardium. Or suppose the valve is changed, the mitral valve that is damaged and that valve is changed by prosthetic valve. Prosthetic valve, and there is one lining on the prosthetic valve. There is a film. When there is prosthetic valve, there is a film which is formed over the prosthetic valve that can catch the bacteria. Or when there is some central line catheter in the newborn, in the NICU management, we usually give the central line catheter. In the PICU, pediatric intensive care management, where there is central line catheter may be done. During that time, there is a film over the catheter that is called biofilm that can catch the. Now, is the infection bacteria directly attached to that? Any damaged endocardium? Matter is that whenever there is damage of the endocardium or endothelium, there is exposure of the collagen fibers below the endothelial layer. When there is any damage of the endocardium or endothelium, there is exposure of the collagen fibers below the endothelial layer. That collagen fibers attract platelets and there are thrombi formation. When the thrombi is formed, then flow of the blood, if there is large number of thrombi are formed, then flow of the blood in the heart or in the artery where the catheter is placed, where there is damage, the flow of the blood is changed to streamlined to turbulent blood. Flow of the blood is changed. Because of the turbulent blood flow, there is deposition of the bacteria or other organisms, fungus or other things that can attach to that platelet aggregation. When the platelet aggregation thrombi is attached with the organisms, then it is called vegetations. So what is the difference between vegetations and thrombi? Thrombi is aggregation of the platelet and fibrous tissue fibrin. But when that fibrin and platelet aggregation is attached with the bacteria, that is called vegetations. And because the bacteria is entrapped within the platelets and fibers, the defense system of our body is very difficult to face that, remove those bacteria. And it is very hard to treat this type of patient. We will have to give long treatments, say 4 weeks to 6 weeks, strong antibiotic therapy depending on the nature of the organisms for removal of these bacteria. Is it clear to you how the infective endocarditis occurs? So, infective endocarditis means there is some infection giving rise to inflammation on the endocardium, and this is not usually due to secondary to some alteration of the flow of the blood from streamlined to turbulent, and that is caused by some predisposing factors. What are those predisposing factors? That is congenital heart defect, one predisposing factors. Suppose that defect is operated. Say there is some cyanotic heart disease. That is one defect. Or the cyanotic heart disease is operated. Or the patent ductus arteriosus is operated. That can give rise to chances of infection of that particular area. Or the subject is taking drugs, intravenous drug user. This constant penetration of the veins can give rise to damage of the endothelium, and then the flow of the attachment of the bacteria and fibrine and other things. Or there is central line catheter. All these things are the predisposing factors. Or the subject is immunosuppressive. Immunosuppressive, taking steroids for a long time. Or say weak from the very beginning. That can give rise to damage of the endocardium. So if there is any vegetations form, so what we are going to think? So this we have discussed this infection, and definitely the pediatrics related cases morbidity and mortality is high. And because early recognition and aggressive treatment is required in this case. So this is already discussed. The more common in children with congenital heart disease, higher risk with prosthetic materials and central lines, and more severe presentations. Definitely. And in adolescents, there are some adolescents in some areas, there are some drug user, intravenous drug user, that can give rise to also chances of infective endocarditis, by infective arteritis, that can give rise to another cause of infection. So these are the risk factors we have discussed just before. You see the risk factors: congenital heart disease, prosthetic valve, previous history, central catheter, immunosuppression, poor dental hygiene. So I think up to this, it is clear to you. And also I think the pathogenesis, how it happens. There is first flow of the streamline to say turbulent blood flow due to this type of factors, deposition of the platelets and fibrous tissue giving rise to thrombi formation, and then it catches the bacteria, thrombi, gives rise to vegetations. So there are two steps. First thing is NBT, non-bacterial thromboembolism. This is the first step formation. And then vegetations, the two steps of pathogenesis. Non-bacterial thromboembolism, reason is clear, and then bacteria attached to it, this is called vegetation. Vegetations, they can enlarge in size. It may be a small one or it may be enlarged in size depending on the nature of the organisms. Not in all cases the predisposing factors may be present. For example, one adolescents who have no heart disease, now suddenly taking drugs, IV drug. So there are predisposing factors IV drug user. Or suppose the subject is not IV drug user, everything is a fit, but there is severe staphylococcal infection. Staphylococcal pneumonia, or say infection in joint arthritis, septic arthritis, or staphylococcal abscess anywhere, incompletely treated, that can give rise to sudden attack of the endocardium. So endocarditis may be of two types depending in the nature of the onset and the presentations. There may be sudden attack by staphylococcal. That can give rise to acute endocarditis. Or there may be say some slow going organisms which may be say entered into the vegetations, very difficult to remove also. Staph also very difficult to remove. That is called subacute bacterial endocarditis. So acute means sudden onset, going rapid downhill course, need immediate treatment, usually caused by the staph. And subacute means it takes time to develop, and they may caused by streptococcal virulence group. Streptococcal virulence is a group of streptococcal organisms, the different types, which may present in the throat and mouth cavity, and usually following dental procedure and other things, it spreads to blood and giving rise to bacteria. So let us do organisms risks. You see, in the neonates usually say there is some catheter is given, another thing is given, central line, chances of staph is very important. And if it takes a long time to treat, or say long continuing antibiotics in a neonate, 14 days, 20 days antibiotics, and baby is not improving, every chance of infection with fungus. And it is our habit to give some sort of antifungal drugs also before sending the blood to blood culture for fungus. And then the antifungal drugs are usually given for management of neonatal infections, which is taking long time, long antibiotic therapy. Second, in the infant and children, staph aureus is usually concerned with the acute onset, which discussed, and other streptococcal virulence, dental procedures, and the enterococcus means when there is some gut infection in the colon, or infection, UTI infection that can give rise to this. In adolescence, there are resistant Staphylococcus aureus, it may occur in adolescents, or particularly drug user, MRSA, and in other things, Hackett group of organisms, usually gram-negative organisms. These are not very important, they are not very huge number of incidents, but Hackett group is difficult to treat and sometimes difficult to culture, and you may get culture negative endocarditis. So endocarditis may be culture positive or culture negative. Hackett group is one of the group. Hackett group means it means the Haemophilus influenzae, you see, Haemophilus influenzae, aggregative actor, Cardiobacterium hominis, and Echinella and Kingella. These species are very difficult to grow, and this Hackett group, sometimes it gives the impression of culture negative endocarditis. Actually, it is not truly culture negative. It may occur. So people sometimes say the culture negative endocarditis is not truly culture negative. If you give the long time, the culture positivity may be there. They are fastidious type of organism, it takes long time to grow. Hackett group is one of that. And second important group is fungi. Very difficult to get the fungus in culture and other things. Difficult to grow. So in immunocompromised fungi and other gram-negative bacilli, maybe culture negative endocarditis, I discussed this. They are really not the culture negative. We are not getting it culture positive. So these are the causative organisms which can give rise to infective endocarditis. Remember, any type of organisms, there is no bound like this. Any type of organisms can give rise to endocarditis depending on the situation. So this is already discussed in the pathogenesis, what is happening there. The non-bacterial thromboembolism is formed, and there is bacteremia, and bacteria adhere to NBT, giving rise to vegetations. Now, what the vegetations can do, let us discuss what these vegetations in the heart can give rise to different problems. Suppose these vegetations are loose and these vegetations are dislodged. These vegetations are dislodged. And these dislodged vegetation, infective vegetations, in going to the brain. What it can do there? What this infective vegetation is going to the brain, what it can do there? Infection, very good answer. Infection in the brain, so brain abscess may be there. Suppose there is endocarditis of the right side of the heart. Right side of the heart. The IV drug user in the brain, and that is right side of the heart endocarditis. And that vegetation is going to the lung. What it may happen? Well, it may give rise to pneumonia, lung abscess, pneumonia. If there is any damage of the vessels, it can give rise to hemorrhage also. Infective vegetations is going to kidney. Kidney, what it can do? So, infective vegetations going to the kidney can give rise to kidney ki korte pare? Nephritis korte pare. This membranoproliferative nephritis. Actually, there is some say whenever there is infective vegetations is going, the body will try to resist the vegetations by forming some immunoglobulin, and there is say immunological complex, immunoglobulin complex, antigen antibody complex. That complex may be deposited in the kidney, and antigen antibody complex deposited in the kidney gives rise to one important disease that is called membranoproliferative glomerulonephritis. What is the important cause of membranoproliferative glomerulonephritis? That is antigen infective origins, antigen antibody mediated disease deposited in the kidney, and that proliferates the membrane. Okay. So, membranoproliferative glomerulonephritis is one of the important components. At the same time, there may be other hematuria may be there because of the damage of the blood vessels. Hematuria may be there, and sometimes there may be failure of the kidney also. Abscess may occur, septic abscess may be there. What problem may occur in the heart of these vegetations? To me, bolo. What it may occur in the heart? These vegetations present in the heart, what may cause in the heart? Quick, don't waste time.
In the heart.
In the heart.
So it may cause ischemia.
Huh?
Ischemia.
So in the heart, the vegetation infection is there. So it can give rise to myocardial abscess, myocardial abscess. Vegetations may enlarge, give rise to myocardial abscess. It can damage the conduction tissue, cardiac arrhythmia. Conduction tissue may be damaged. It can give rise to cardiac arrhythmia. It can give rise to abscess. It can perforate the quadi tendini because of the infection. Then the prolapse of the valve. So it may give rise to regurgitant murmur. So there may be appearance of the new murmur because of the infective endocarditis and because of the damage. So it can damage the valve, it can give rise to abscess formation, it can perforate the quadi tendini, there may be micro abscesses there, new structures may be damaged in the heart. So lots of things may happen depending on. Suppose there is some say immunocomplex is deposited under the pulp and there is some swelling, the swelling of painful. These are called ossular nodes. Sometimes there may be hemorrhages in the nail bed, splinter hemorrhages, hemorrhages in the say behind the retina, retinal hemorrhages, blood spots. These are catchy names. Really. Now infection is spreading in the blood vessels. What may occur there? Spleen may be enlarged, splenomegaly may be there. So any type of manifestations may occur in the case of infective endocarditis. That's why it is very important to know the different diseases of infective endocarditis. Naturally, as it is infection, just like it is very difficult to detect also. But there is a rule. Rule is that if there is congenital heart disease is present, suppose you know the patient is suffering from congenital heart disease, particularly left-sided disease, VSD or PDA, or say any cyanotic congenital heart disease, Eclosia Fallot or TGA or other things. In those cases, where there is more pressure of the blood flow from one side to the other, there are chances of the damage. Where there is no clearance of the organism, for example, in case of Eclosia Fallot, normally right-sided blood is cleared from the bacteria in the lung. In the lung, there are macrophages, they engulf the bacteria. Suppose that bacteria is not cleaned properly. In case of Tetralogia Fallot, the aorta overrides the right ventricle. In case of transposition of the great arteries, the aorta takes origin from the right ventricle. So in those cases, there are no chance of clearance of the organisms in the lung. In that cases, chances of infective endocarditis are higher. Or where there is jet flow of the blood, high pressure flow, patent ductus arteriosus, ventricular septal defect. Left ventricular blood pressure is 100, average mean pressure during systole, right ventricle is more than 20. So if there is 80 millimeter difference or PDA, aortic mean pressure is 100 and pulmonary artery mean pressure is 15 to 25. Average is 25, 75 millimeter pressure difference. There are every chance of damage of the endothelium, NBT forms and vegetations may occur, and that can give rise to infective endocarditis. In those cases, if there is a dental procedures, as there is a vegetations, bacteria are present within the vegetations, presentation may be sometimes difficult to detect. There may be low-grade fever, except in acute conditions where the Staphylococcus infection is there may be high fever and sudden presentations, sudden catastrophe. But in subacute cases, there may be low-grade fever, malaise, lethargy, child is not interested in playing, feeding, say, appetite is reduced. All these things are non-specific symptoms may be present as a general measures. And when we examine the different areas from head to foot and other systems, the heart and other things, you will get some things which we detect. It may be a case of infective organ. So any cases of fever in a known case of congenital heart disease persisting more than 10 days. Any cases of fever in a case of known cause of cases of congenital heart disease persisting more than 10 days should be considered as infective endocarditis unless proved otherwise. Clear to you? Unless proved otherwise. So sometimes this type of question may be given. A child is say 5 years suffering from ventricular septal defect, is presenting with fever for more than 2 weeks, low-grade fever, lethargy, and the spleen is palpable. What will be your first diagnosis or most important diagnosis in this case? Let us go to the site again. So clinical features in general say persistent fever, lethargy, poor appetite, weight loss, night sweats, arthralgia, non-specific signs, non-specific. This is important. New or changing heart murmur. The reason is known to you. There is damage of the valve anywhere, can give rise to new murmur, or the murmur which was present as VSD, now you are getting another murmur like say aortic regurgitation or other things. And cardiac failure, the signs of cardiac failure may be there, as there is multiple abscess present in the myocardium is becoming weak and there may be failure. So cardiac failure, every chance of there is cardiac failure in case of infection. And conduction abnormality, I have discussed, there is a conductor fibers they are damaged due to this. In the brain, you see this stroke and brain abscess are common. It may occur, or sometimes the arteritis may be there, small venous arteritis may be there. Sometimes they present with some say tangential lessons or any other, say, depending on the site of the involvement of the artery. This is not the fixed that stroke and other things. Anything may happen there. And pulmonary septic emboli may be there. Sometimes pulmonary hemorrhages may be there if the vessels are damaged. Pneumonia may be formed in the lungs. And say renal hematuria, in fact, discussed, and also there is very important discussion of membranoproliferative glomerulonephritis that may occur here. And in the limbs, suppose in the limbs if one blood vessels is blocked by vegetations, so that is called emboli formations. So you see the management of the infective endocarditis depends on the what type of pathogenesis is occurring. Is it the bacteria causing direct damage, or some emboli causing the damage, or there is some immunocomplex deposition? For example, Osler knots, immunocomplex deposition. Membranoproliferative glomerulonephritis, immunocomplex deposition. Okay, but emboli causing damage of the vessels and bleeding, splinter hemorrhage. It may occur in any other condition. Suppose there is trauma to the nail bed, it can give rise to hemorrhage. Okay, broad spot, there is also some hemorrhage, the blood vessels. So there is, or some emboli like this, causing rise to blocking the artery, ischemia may occur. Ischemia and petechiae may be formed from the skin. So clean rashes may be there. And that is maybe due to thrombocytopenia also. So these are genoillusions is the same painless macules in the palm. Painless macules in the palms, you will see, go and see the books that painless macules on the palms with patients. That is discussed, all these things. Now, how do we diagnose the infective endocarditis? Now, modified Duke criteria, this is important for the diagnosis. Now, two important things is that you will have to prove that there is some, say, infection present in the blood. So, you will have to do the culture of the blood. So, you will have to take the blood for the culture. If the child is also, remember, for the culture, it requires mostly the culture requires aerobic, but there are maybe some anaerobic organisms may be there. But sometimes in small child, suppose the 2 years old child, you can take only 3 ml, 2 to 3 ml of blood. In that case, anaerobic culture is may not be possible. Aerobic culture is only done. But it is better to take a greater amount of blood to do the all aerobic and anaerobic cultures together. So usually 3 to 5 ml of blood is taken, but according to some, more than 5 ml, 5 to 8 or 5 to 10 ml blood should be taken in older children. And that should be taken from 3 different sites. 3 different sites, not 2. Previously it was for 2, but this year it changed. In 2025 it is changed to 3. So 3 different sites you should take the blood at an interval of at least 1 hour. So 3 times you should take the blood at an interval of 1 hour and from 3 different sites. So think how much importance is giving to prove that is infection is present in the blood. Okay. So if it is positive, that gives one thing. And second important thing is that both should be present. That in the echocardiography, usually in pediatrics, the transthoracic echocardiography can give rise to vegetation detection of the vegetations. Echocardiography can give rise to detection of vegetations, detection of the abscess in the heart, detection of any valve damage or murmur, etc. That can give rise to the good echocardiographer experience. So these 2 are major criteria for diagnosis of infective endocarditis. There are some minor criteria also. Suppose there is some, say, this fever, heart conditions, which I have discussed. Any patient presented with fever for more than 10 days with known case of congenital heart disease, in that case you should consider as infective endocarditis unless proved otherwise. These are minor criteria. And you see the vascular phenomena, GNA, emboli, etc. Immunological signs also are so pulmonophytis, blood spots, and microbiology evidence not meeting measure. This is not an important one. So major criteria should be fulfilled, and these are the definitions, Duke criteria. If there are 2 major criteria present, your diagnosis. Echocardiography, you are getting the vegetations, culture is present, so there is no questions of any alteration of the diagnosis. It is there. Echocardiography and culture is both present, it is there. ঘুমোচ্ছিস নাকি? কি বলছিলাম? হ্যাঁ? না কি ক্রাইটেরিয়া বলছিলাম? হ্যাঁ? বলো, ডিউক ক্রাইটেরিয়া বলুন। থ্যাংক ইউ, ঠিক আছে। তাহলে অ্যাটেনশন দিয়ে শুনছো তো, ভালো কিছু। ঘাড় হেড করে, হেড ডাউন করে অ্যাটেনশন দিয়ে শুনছে। মন্দিরা, তোমার ছাত্রী ঘাড় হেড করে, হেড ডাউন করে, স্ট্রং অ্যাটেনশন দিয়ে শুনছে, কিন্তু বলে দিচ্ছি উত্তরটা অ্যান্সার ইজ কারেক্ট। ঠিক আছে, আমাদের কোনো গিভেন্স নেই, তোমার অ্যান্সার ইজ কারেক্ট। So, if there is two major criteria are present, we should say that it is sure. Or one major plus three minor, or five minor criteria. This is definite diagnosis of infective endocarditis. Possible infective endocarditis where one major plus one minor or three minor. And rejected is alternative diagnosis or resolution in less than 4 days. Rejected. So remember, the strong importance should be given in infective endocarditis because you will have to follow up the case for a long time. Right? As there is a damage to the heart, you will have to follow up the case for a long time. Prior to starting anti-health guide therapy, now where the imaging usually turns thoracic, means you give the probe here, but sometimes turns esophageal echocardiography is better. But in children, usually turns thoracic suffices. Transesophageal echocardiography medicine should be introduced in the esophagus, and then you keep the patient. It may be feasible in older children or adults, but transthoracic should be in the smaller children. These are the other general examination you see. You will get definitely anemia will be there, as there is infection present for long time. Anemia will be there, and there will be leukocytosis. CRP, ESS is there. Rheumatoid factor may be positive. This is not important one, and urinalysis microscopic hematuria may be present. These are the non-specific investigations which are required. ECG, you see the PR prolongation and AV block. Reason is known to you because conduction block. And in cardiology, you see you can get the cardiomegaly when there is a weakness of the heart and cardiac failure is going on, and pulmonary infarct. CT or MRI for embolic stroke or abscess, if there is brain manifestations there. Antibiotic therapy, actually, there are conception of that, the native valve. Native valve means the valve which is not damaged before. And damaged valve, where the valve is already there is some incompetence or stenosis there. And the prosthetic valves, where the valve is replaced. Prosthetic valve, particularly when it is replaced, there is a stitch is given that is called sewing stitch at the periphery. And through that stitch, there is formation of one biofilm over the prosthetic valve. And the bacteria can enter over the platelets can enter over the biofilm. Along from stitch line, it starts across the valve. And the NBT is formed, non-bacterial thrombus embolism, and then vegetations after catching the bacteria. So, in case of native valve, or the staph is most important source of organisms which give rise to this. So, ampicillin and gentamicin, remember always for 4 to 6 weeks. And you can alternate the other, like say, if there is a medicine resistance, if it is a resistance staph, you can give vancomycin also. Or if it is prosthetic valve, vancomycin, gentamicin, rifampicin. All these are for 4 to 6 weeks. And in case of Streptococcus viridans, till now the penicillin is good drug. Penicillin and gentamicin for 2 weeks and penicillin or ceftriaxone for 4 weeks. With methicillin sensitive Staphylococcus aureus, naphthalene and gentamicin only for 5 days. Yeah. 6 weeks. Resistance, add vancomycin 6 weeks. Enterococci, these are Hackett group ceftriaxone, and fungal definitely amphotericin B and surgery. Remember, all this you may not commit from the memory, it is very difficult to that. Okay, treatment portion. Just go and see, read the books, and just learn what drugs are usually given for infective endocarditis. Now, monitoring during the treatment, the more important thing is that repeat blood culture until it is sterile. This is important. You should not leave the patient. Fever is improved, everything is improved, so go home. Is that. Monitor renal function, drug levels, gentamicin is important. and repeat echo is worsening or no improvement. Sometimes the patient condition is not improving. Vegetations is enlarging, or cardiac failure is not responding, or the high fever is present. All these things, other new complaints are arising. So all these things requires some surgical procedures along with it, or fungal infection particularly. Fungus, very difficult to treat. You are giving amphotericin B and other drugs, but the fungus is not improving, large fungus. You should do the surgery here. So indications for surgery is that when there is refractory heart failure, uncontrolled infection, large vegetations, prosthetic valve infective endocarditis, or fungal infection. You will have to do the surgery. You have to follow up for the long time. I think these are the common things which are required to know for infective endocarditis. So prevention means, in general principles means, identify high risk patients, family education is important, and emphasize oral hygiene. This is important. Oral hygiene is very important, because if there is a repeated tooth abscess or intervention, bacterial chances are much more common. Prophylaxis, previously during our time we thought that VSD cases or PDA cases, they require prophylaxis, but ASD does not require any prophylaxis in our time. But subsequently it is changed. It has been found the VSD with infective endocarditis incidence is more or less same as native valve or native heart conditions. So incidence is not higher. For giving prophylaxis, you cannot prevent infective endocarditis more than normal person. So prophylaxis is not needed in VSD. It is not needed in PDA. The prophylaxis is needed in case of prosthetic valves and materials, history of infective endocarditis previous, or unrepaired cyanotic heart disease. Prophylaxis is needed. Repaired heart disease with prosthetic materials, less than 6 months, or say residual shunt or defect heart transplant with valvulopathy. So in case of VSD, chances of infective endocarditis is much more if there is tooth procedure there. But prophylaxis against infective endocarditis are not recommended till now. The reason is that the incidence by giving prevention by giving prophylaxis is not sufficient enough to support the prophylaxis. Rather, it can give rise to resistance to antibacterial resistance in the children. So that is removed. Remove for it. In case of say any in other conditions where there is say you are doing some manipulation of the infected genitourinary tract, or you are doing some manipulation of the infected gut, in that case also, so it is normal the prophylaxis is given there. Dental procedures is very important. Any type of dental procedures and involving gingiva, periapical tissue, oral mucus perforation. But routine care, routine cleaning, ortho appliances, they are not required for prophylaxis. GI is human skin, which I just discussed. If there is infection present, you should give the prophylaxis. Okay. So what the drug should be given? Only amoxicillin 50 mg per kg, or in case of resistance, you can give azithromycin 50 mg per kg or clindamycin 20 mg per kg, single dose. Single dose, half to 1 hour prior to intervention. I think this is all about your infective endocarditis. Thank you. So As we have 10 minutes, 7 minutes আছে, so 10 minutes there, so I should recapitulate and ask questions to things. তোমার বসো 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 বসো। What is infective endocarditis? Very good. Infection of the endocardium. What is infective arteritis? Infection of the endothelium of the artery. Artery বললো হয়। What is myositis? Infection of the muscle. What is pericarditis? Infection of the pericardium. Inflammation of the pericardium. Inflammation বললো তো? Inflammation. সব ইনফেকশন আইটিস মানে হচ্ছে ইনফ্লামেশন। আমরা কমনলি ইনফেকশন নিয়ে ডিসকাস করছি বলে বেরিয়ে যাচ্ছে। তুমি বলো, what are the say tell me 2 important predisposing factors for infective endocarditis? না, congenital heart defect আর very good, any congenital heart defect or valve defect. তুমি বলো, what are the different types of infective endocarditis? Acute, subacute, or acute and subacute. তুমি বলো, না না এই যে মাঝে তুমি বলো, why acute infective endocarditis may occur? What is the usual causative organisms for acute infective endocarditis? তো বলে দিচ্ছে কেন, বলে দিচ্ছ কেন তুমি? আমি শুনতে পাচ্ছি, বলো। Staphylococcus. What are the usual causative organisms of subacute infection? Subacute কি বলেছি? causative organism usual কি বলেছি? subacute, হ্যাঁ তুমি বলো বলো বলো। কি রে তোমরা, হ্যাঁ দাঁড়া না, উল্টো পাল্টা বকিস না, ফাঙ্গাই বলেছে, হয় বলবে না, চুপ করে। হ্যাঁ, স্ট্রেপ্টোকল ভিরিস, এই তো অ্যান্সার। তুই তো ওখান থেকে জিজ্ঞাসা করি, একে জিজ্ঞেস করছি। স্ট্রেপ্টোকল ভিরিস কারেক্ট অ্যান্সার। এত পড়ি শেষ পর্যন্ত এই অবস্থা গুলো তো মুশকিল। হ্যাঁ, স্ট্রেপ্টোকল ভিরিডাস, ঠিক আছে। Causative organisms for infective endocarditis usually in newborn who is taking who is taking say central cannula for long time, newborn, more than 15 days antibiotics, admitted in the NICU, and central cannula is giving for drugs. তাড়াতাড়ি বলো, causative organisms। Staphylococcus তো হতেই পারে, ভালো কমনটা কি ভাববো আমরা? 2 weeks antibiotic therapy, central line is given, infective endocarditis is there. Anyone from the left side? No answer. Anyone from the right side? Long continued antibiotics more than 12 days in a newborn, admitted in the NICU, and there is central cannulation. What organisms can give rise to infective endocarditis in this case, other than staph? Intercoccus পেটে হলে হবে না? হ্যাঁ, রাইট সাইড এনিওয়ান? বলো বলো, কে বললো? কি বললি? Fungus should be the answer. Fungus, candida বলেছিস? আমি বলার আগে বলেছিলি ক্যান্ডিডা বলবো না, ক্যান্ডিডা আলবিকান্স আর অ্যাসপারজিলাস, এই দুটো খুব ইম্পর্টেন্ট।